Good day, my name is Tom Heath. I'm a WASH Technical Advisor with Action Against Hunger, and today I'm going to be presenting implementation and effectiveness of case area targeted interventions, CATIs, in cholera response. This research was led by Johns Hopkins and was implemented in the field remotely by Action Against Hunger and Solidarities International. It was funded by BHA. And today I'm just going to be presenting some of the preliminary findings and reflecting on some of the operational components. So, a little background. Last year, Johns Hopkins met with a range of NGOs looking to find locations with cholera, with NGOs that were planning to do CATI, that were emergencies, and locations where field researchers, Johns Hopkins researchers, could be deployed to the field. We were not sure, we didn't have a great list at the time of locations. We were skeptical that we were going to be able to line all of those pieces up. And in fact, what happened was in Nigeria last year, we had one of the worst cholera outbreaks in a decade, and ACF started responding using CATI, which is something we're trying to do more systematically since we developed our cholera SOPs. And as a result of that, we reached out to Johns Hopkins and said, hey, you can't come due to security, but we can try and do this study remotely. And then Solidarities likewise ended up also responding to the cholera and linking up with Johns Hopkins. Now, just on the CATI, for those that aren't familiar, this diagram is often how I explain it. It's based on the fact that the households surrounding a cholera patient have 36 times the risk of contracting cholera. So if we can use a rapid response team to target the household and the surrounding neighborhood households, we can try and reduce the risk. And that's what we tried to do. This is operational research. It was a prospective observational study done remotely, and the primary objective was to evaluate the effectiveness of the CATI approach in reducing the cholera case incidence, specifically what happened in the case household and the neighbour households 2 weeks after the intervention. In terms of the study design, the main data collection was done over 2 phases. Observation of the CATI interventions at the households, and the second phase, it was a week or 2 weeks later, with follow-up interviews at the CATI and surrounding households. And this was all using GPS so we could sort of trace the specific location of where people were. And this was supported by key informant interviews, both CATI teams, NGO leads, managers and other agencies. Now, this research was designed to have field researchers present. It wasn't designed to be remotely done. And this introduced some complexities in undertaking the research. So in terms of what is actually done during a CATI intervention by ACF and Solidarity, so we have this 150-meter radius that we talked about. Then in terms of the interventions, at the case household, there was a cholera kit, so there's an extended hygiene kit. There was hygiene promotion, there was testing of the free chloro residual of their water source, and there was spraying. Solidarities actually had 2 different concentrations, depending if they were spraying the toilet or spraying other locations. ACF, it was a single concentration. In addition, there was also case referral, identifying if there were other people who were sick with cholera who were advised to go to the CTC. Right, so we've done this intervention at the case household, and now we're going to go and look at the neighbour household, and they were given a simpler hygiene kit, so that's soap, aqua tabs. There was hygiene promotion, again there was spraying, and there was testing of free chlorine residual. In terms of teams, ACF were operating at 10 teams across 2 states, and Solidarities had 10 across 3 states. And I think we were looking at around 6 CTCs in total used as the base for this operation. I mean, in terms of operationally, what happens, the team would go to the CTC in the morning and they take the line list. They look at who's sick, and then from there, that's how they'd head out. That's sort of what the actual response would look like. And this relationship is crucial when you're considering undertaking CATI. So we have here 3 epicharts from Nigeria. Now, as I mentioned, this is one of the worst cholera outbreaks in 4 years in Nigeria. There was a huge number of cases, really concerning. And what you can see on these epicharts is the timing of the interventions of the organization. And you can see for Yobe and for Borno that the 2 agencies
one of them was at the peak, and then one of them was a bit too late. And the point of CATI is to be at the start. The idea, the intervention logic, is to stop it before it spreads. It's always nice to plot at what point did the intervention start to see whether this is pertinent or due to other factors. And you can, well, we'll when we get the results, we can explore more some of these questions around the timing. Let's walk through the actual data collection. So phase 1, a sick person presents themselves at the CTC and is diagnosed with cholera. The rapid response team is mobilized. They go find this household, they do the intervention, then they go to the neighbor households. All of this is mapped, and that's what you can see on this map. You can see the green dot at the center, which is the CATI ring, and the blue dots, which are the neighbors. So 2 weeks later, phase 2, they return to that cholera household, and they return to a range of the neighbors' households within that 150 meters, not necessarily the same individuals. These data sets are then combined. So having GPS data for every single household is very powerful, but because this was done remotely, the data management raised a lot of issues. And we have to be able to, or the researchers had to link this phase 1 and phase 2 data. And that was not easy.
As I mentioned, John Hopkins is still analysing the data. There was a lot of data cleaning. And today I'm going to present some of the preliminary results around the first phase of the CATI implementation. This table is showing the number of case households and neighbour households who were reached during the intervention across the different states and NGOs. In total, we're looking at around over 2,000 case households who were reached during the CATI and around 53,000 neighbours. So we're talking about for every CATI, there was around 23 neighbours who were then also targeted during that intervention. And I'd say around 50-60% of the line list was reached during this CATI intervention, this research. What you're looking at here is the timeliness of the response for ACF and SI. The bottom lines are 0 to 1 day, and the top line is greater than 3 days. And what we see is the majority of the CATIs were implemented between admission and day 1, which is good. Where we did have variation, it was across some of the other local governments areas where the time was longer due to security, the caseload, distance, the size of the team. ACF, for example, was working through government teams, and that sometimes restricted our efficiency. What we're looking at here is what was done at the case households, the graphs on the left, and the neighbour households, the graphs on the right, for the different interventions. So was there distribution, was there spraying, was there hygiene promotion? And the key point is there was variation across the states, which you can see with the different lines, the different colored lines, and the variation between those. So in terms of preliminary conclusions, there were 2 that stand out. Firstly, the importance of monitoring geo-targeting information for ensuring correct CATI implementation, so both the households and the neighbour households. And secondly, the challenges of conducting research during first phase emergencies was difficult. In terms of these operational aspects, so having online monitoring, where we had an in-water dashboard where we can see where the teams were going, we could see how long they were spending on site, we could see whether they were respecting the SOPs and give that feedback, that was powerful. And that links to this sort of broader question, which was a challenge with the 150 meters. You can see on the graph on the left the range of interventions. The red is the case household, and what we have here is, it's not 150 meters, it's in a line because it's along the street in a dense urban area. How does the team respect that 150? Personally, now on reflection, I think 150 is big. I mean, we were looking at between 20 and 40 households just within the 150. That's a lot, and we spent a lot of time looking at these rings and trying to improve this. And this, what you can see, is an earlier version, but this was difficult and is a key part of doing CATI, is ensuring the adherence to that protocol. Obviously, is Northeast Nigeria. We had issues with security, we had issues with access, we had issues with logistics, but I think in particular it was, ensuring the protocol was respected that was a challenge. We had really good relationships with the CTCs and the medical teams. On the research side, we had, I think a key point was having a research officer dedicated to this was crucial, because we're doing it remotely. We had to have someone who was the focal point for the researchers, who could link in with them. It was an observational study, but at the same time, the data the researchers were generating, we were using to modify our responses, because in real time they were identifying issues such as the rings, and then we were adjusting that. So this then impacted the research. As I said, research done remotely, hard in a fluid context. So thank you all for your time, and I'll be happy to take questions.